Welcome to the Practical Dermatology podcast. From the editors of Practical Dermatology, I'm Rana Jaraha. In our top story, newly approved rosacea treatment, Emrosi, is now commercially available. Journey Medical announced the launch and initial prescriptions for Emrosi for the treatment of inflammatory lesions of rosacea in adults. Approved by the FDA in November, once-daily Emrosi combines 10 mg immediate release and 30 mg extended release minocycline, providing the lowest dose oral minocycline available for rosacea treatment. The approval was supported by positive data from 2 phase 3 clinical trials. Emrosi demonstrated statistically significant superiority over both the current standard of care treatment, Oracea 40 mg, and placebo for investigators' global assessment treatment success, as well as the reduction in total inflammatory lesion count. There was no significant difference in safety compared to Oracea and placebo over 16 weeks. Journey Medical said Emrosi is now available by prescription and will be coming to specialty pharmacy chains. At the recent American Academy of Dermatology meeting in Orlando, Dr. Linda Steingold, Director of Dermatology Clinical Research at Henry Ford Health System in Detroit, presented new research regarding tapinarof 1% cream, which recently received FDA approval for atopic dermatitis. Dr. Steingold, who was a principal investigator in the Adoring 3 long-term extension study, shared the main findings of the research with Dermwire TV.
And the way the study was designed is that we allowed patients to continue to use medication every day, the 1% tapinarof cream, until they got to completely clear skin. After that, they stopped the medication, and we waited until they got to mild disease or worse before they restarted the medication. And what we found was, for a lot of these patients, actually the majority of patients, they were able to get to clear, almost clear. And of those patients who got to completely clear skin, on average, they had 80 consecutive days of using no medication before their disease got to mild or worse. So that's the possibility of a bit of a drug holiday, which is quite nice. And it's not something that we really think about when treating a chronic disease.
To view the full segment with Dr. Steingold, visit the Dermwire TV section of practicaldermatology.com. And now for a new C-Suite Chat segment in which executives in the dermatology and aesthetics industries provide first-hand accounts of the company's research goals and pipeline development. In this week's episode, we hear from Arielle Moody, CEO and co-founder of Mama Sol. Ms. Moody talks about what makes Mama Sol's mineral-based sunscreen different from other products on the market. Here is a portion of that segment.
Mama Sol is a 100% mineral sun care brand that we designed intentionally to be safe and effective for sensitive skin, pregnant or nursing women. And the formulas go on white, so you can see where you apply them and you don't miss a spot. And with the warmth of your fingertips, they blend into your skin in seconds. We are one of the only mineral sun care brands made without silicones. Silicone tends to suspend zinc oxide to help prevent separation, but it also is not biodegradable and it tends to clog your pores. So that's another way that Mama Sol is tackling sustainability and then also self-care.
Ms. Moody also discusses the importance of sunscreen as self-care and the clinical testing of Mama Sol's skincare products. Now, for today's interview, Practical Dermatology Chief Medical Editor Dr. Neal Bhatia is joined by Dr. Matthew Zirwas.
Hi, I'm Dr. Neal Bhatia. I'm Chief Medical Editor of Practical Dermatology with my friend Dr. Matthew Zirwas. Matt is the Associate Professor at The Ohio University. And Matt, we're going to talk about a study which is interesting. Yeah. It's the efficacy and safety of upadacitinib versus dupilumab. This is again in adults and adolescents, moderate to severe atopic dermatitis. There's a week 16 data point that was in this open label randomized study.
Yep.
They were basically head-to-head, obviously.
Yep.
Everyone knew what they were getting, shots versus pills, obviously.
Yep.
What were you hoping to see in that study? This is a phase 3B and a 4 study kind of mixed.
So the thing that I was hoping to see, I actually didn't get to see. So we knew from Heads Up pre-launch, where they did a randomized double-blind placebo-controlled dupilumab versus upadacitinib 30 milligrams. The upadacitinib 30 milligrams is more effective than dupilumab.
Yep.
I already knew that. This study, they phrased it as its real-world use. And so what I was hoping, before I forget to get back to that, was to see, okay, how does upadacitinib 15 compare to Dupy? Mm-hmm. But the study didn't answer that question. So here's what they did. Everybody started on Dupy or on UPA 15. At 4 weeks, if you weren't 50% better, had EASI 50 or NRS 4-point improvement, itch NRS 4-point improvement, you got increased to 30. you got dose increased. Then at 8 weeks, if you weren't EZ75 and NRS4, you got dose increased to 30. So 70% of people got dose increased to 30.
Which was nice because at least that dose ranging element was there.
Yes.
And that's very real world to think,
very.
okay, I could actually now have something that stands behind jumping the dose.
Yes.
And to be fair, we would probably check some more labs.
Yes.
Like whenever we increase the dose, we do that. But anyway.
And so it's useful data, and it reconfirmed for us. So roughly 24% of upadacitinib treated people got to EZ90 IJ01. Roughly 9% of Dupy people got there. But so mainly since 70% of people got dose elevated, basically it told us again, upadacitinib 30 is better than Dupy.
Exactly.
But there's value in confirming the results of a prior trial. Second, it reconfirmed for us some of the safety things. So, with Rinvoq now, with upadacitinib now, the data keeps coming in more and more. They got 6-year safety data now, 30,000 years of patient exposure.
And constant indications changing,
And no MACE risk, no VTE risk, and if anything, upadacitinib substantially decreases those. So this again confirmed, didn't see any MACE or VTE events. The one thing we did see increase in herpes viruses.
Okay.
And so we knew that's the one thing that upadacitinib affects in your immune system is HSV and VZV.
Which reminds me, I've heard you say this before. There's a strategy you like with getting the vaccine on board.
Yes.
But the zoster vaccine.
Yes.
But what do you like?
I do too. So the zoster vaccine you can give before or after they're on drug. It is essentially seems to be close to 100% protective against zoster. But everybody that I start on UPA or Abro for atopic derm gets valacyclovir 500 milligrams a day.
Okay.
Because eczema herpeticum is about 1 in 40, 1 in 50 patients.
That's miserable.
And the vaccine, zoster vaccine, isn't going to protect you from that.
Right.
So I keep people on the valacyclovir 500 once a day as long as they're on.
And that's a low dose prophylaxis like we would do for labial.
Right. If you came in, I get 3 cold sores a year. We'd be like, here's 500.
Bingo.
The other things that it again reconfirmed for us: 2% of Dupy treated patients got arthralgias. 1%, or to be exact, 0.9% of upadacitinib treated patients got arthralgias. So that tells us about 1% of Dupy patients get arthralgias. We kind of knew that was the case, so that was interesting as well. Conjunctivitis, 7% of dupilumab treated patients got it, exactly what we expect.
Yeah.
So it reconfirmed all of our safety stuff.
That's what we need, and that's how dermatologists now have the talking points to choose. And we'll talk about that in a second. And again, to be just a little more fair balance. Abrocitinib had a very similar trial. 200 milligrams, subbing for what upadacitinib would be 30.
Yep, and so, Abro did a better pre-launch trial because we know we have a head-to-head of Abro 100 versus Dupy. We have a head-to-head of Abro 200 versus Dupy. We know the 100 is equally effective to Dupy at 12 to 16 weeks.
Yep.
We know the 200 is more effective than Dupy at 12 to 16 weeks. We know for Rinvoq, or for upadacitinib, I can say 30 is definitely more effective than Dupy. I can't say that about 15.
There.
Right? I can't say it is as good as Dupy. I can't say it's better than Dupy. I don't have head-to-head data.
Well, it's funny because we've seen the curves, right? You break that itch scratch cycle faster with the JAK inhibitors.
Yeah.
But by week 16, they're at the same place.
Yeah,
at that low dose. At the higher dose, we definitely see that.
Yep.
Now, just to kind of side with that, what do you like to tell patients? I'm your patient now. Talk to me about choices. I got 20% of my body covered. I'm scratching up a storm, can't sleep.
Yep.
Tell me what's our conversation like?
Here's my conversation with somebody.
No asthma, by the way.
Right. No, that's what I was going to say. First thing is, do you have asthma? Do you have bad allergies?
Yep.
If you've got asthma or allergies, it's kind of the end of discussion. I'm going to recommend Dupy.
Right.
If they don't have asthma or allergies, my discussion goes like this. And actually, even before we go to therapeutic, it's a really interesting thing now how we explain atopic dermatitis to patients.
Right.
So historically, when a patient said, "Why did I get this? I didn't change my diet. I didn't change my products. I didn't move. I didn't change." And basically, my answer used to be, "Well, your skin got old. It doesn't work when it's old." Now we know there's a guy at the NIH who's proven pretty well that indoor and outdoor air pollution are damaging your barrier over time. And so now what we can say to that person is, and it's exactly the skin cancer conversation we have when somebody's like, I use sunscreen like you said, I cover up. Why did I get this skin cancer?
Right.
Well, it's not the sun you got last year, it's the sun you got 30 years ago.
Bingo.
So now, why did I get this? Well, the chemicals you've been being exposed to your whole life have been slowly damaging your skin, and that damage just built up to the point that now your skin is not protecting you from the environment anymore.
Yeah.
Patients love
That's actually really good.
that answer.
Yeah.
Right. The other thing that we now have a better answer for is diet, because the other thing you hate from, well, I ate a tomato and I flared, but then I ate tomatoes and corn together and I didn't. And so what about purple foods? And what do I need to? And you're just like, I should go see an allergist.
Yeah,
Shut up, I don't
please.
care.
Yeah, I don't care.
Right. Yeah. Now we know the way that food is impacting the atopic dermatitis is via the intestinal microbiome. A healthy intestinal microbiome is supposed to be producing short-chain fatty acids that are anti-inflammatory, and it is supposed to be producing tryptophan metabolites that activate the aryl hydrocarbon receptor. And so when your microbiome is unhealthy, so in other words, air pollution is getting your skin, food pollution is getting your gut. And you stop making those short-chain fatty acids, you stop making the aryl hydrocarbon receptor activators. Aryl hydrocarbon receptor stimulates a healthy barrier. Mm-hmm. The short-chain fatty acids are anti-inflammatory. And so when your gut gets out of health, you stop making that stuff and it makes your eczema worse. And the reason why the food stores are also confusing from them is your intestinal microbiome is always changing. Yeah. So there's going to be, sometimes this food's going to seem like it makes you flare, sometimes that food. And so instead of trying to figure out what they need to avoid, we've got randomized double-blind placebo-controlled trials supporting the use of probiotics. And so I put people on I say, you don't need, yes, food is definitely a big issue. Yeah. It's all the crap in the food supply, the food additives, the preservatives, the hormones, antibiotics, but you can't get your eczema better by doing that, but start taking this probiotic. Exactly.
Well, that gives them some validity in why they want to do it in the first place.
Now they like you more, and they're more going to listen to your, because it used to basically be, my spiel was like, I don't know why you got this. Yeah. Diet's not an issue. Take this drug.
Exactly.
Right? Patients don't want that. So now I'm like, well, here's why you got it. It's a pollution. It's a food. Yep. Here's a natural, healthy probiotic.
And you're joining them in the blame game, right?
It's easy. Great. Yes. Yeah. And so now, but that probiotic, it might take years if it's going to work or not. So but luckily for you, we've got amazing medications now. And I'm going to give you really a few choices to see what would be best for you. So we could use a pill. You won't have to give yourself any shots. It slightly affects your immune system. The only thing it does is make you get more cold sores. Mm-hmm. It is the most effective thing we've got. Or we can treat you with a shot. You're gonna have to give yourself a shot every 2 weeks. Doesn't work quite as well as the pill, but it doesn't affect your immune system at all. And if anything, it actually makes your immune system work better. Right. Which one do you want to go? Which one sounds better? Yeah. And most patients, given that, if they're not needle phobic, so if they're needle phobic, they're going to say, "Oh, I'd rather take the pill." Right. And if they're not needle phobic, they're likely to take the shot, right? Unless they're really concerned about, I want the most effective thing. Yeah. And then if they say I want the shot, then it's, well, great. You're going to take it, 2 shots your first dose. Then you're going to take 1 shot every 2 weeks. Your eyes might get inflamed. Yeah. Might get some achy joints. It really. We don't have head-to-heads to be able to say Dupey's better, Lebrie's better, Tralo's better. So with the shots, it then also becomes Dupey's been around the longest, nemolizumab has the fewest shots. Right.
And we know there's access issues too. Yes. Take all those aside. The biggest thing, though, which I know you like to do, which I like to do, is have the patient audition in front of us. Right. Yeah. Make sure they can do the shot in front of us. Right, that's one big one. And then the second thing is if you think about their lifestyle. In college, I have a lot of Navy patients. You get a lot of patients, they travel for work, whatever else. These are the patients do you want to take shots with you, or do you want to just take your bottle of pills?
And the last thing I want to talk about, and again, this is quick, is how you talk about the box warning. So let's say the patient says, "Oh, I can't imagine giving myself a shot. I want to take a pill." Okay, so just to warn you, you're going to get some information from the pharmacy that talks about some scary sounding things. Yeah. When this medication first came out, we didn't know if it increased them or not, and so they put those warnings in. Now we have 30,000 years of patient data that have shown no risk of any of these things. Yeah. Now, what are the things? The scary side of things: heart attacks, strokes, blood clots, cancer, death. But again, 30,000 years of data.
Yeah.
No data that suggests any risk of those
That's
things.
just it. There's a risk, and then this is what's going to happen to you, right?
Yeah.
These are the things we have to separate
Yes.
in their heads.
Yep.
And the box warning, the stormtroopers aren't going to come and take your prescription pad away.
Yeah, nope.
There's just, these are the things we watch for.
Yep.
Well, Matt, this was really good, and this was a really good conversation for the podcast, and we'll do this again soon.
All right. Great. No, this was fun.